Welcome to this Boston Scientific sponsored session on preserving coronary access after TAVI. My name is Søndergaard. I'm based in Copenhagen in Denmark. I'm delighted to be joined here by Ignacio Amat-Santos from Spain and Federico De Marco from Milan in Italy. So this session will be based on a case. So I will start in a minute with the case presentation. Then Ignacio will take us through how the ACURATE Neo2 device is working. We're going to see a case in a box demonstration focusing on preserving coronary access. And then finally, Federico is going to take us through the techniques to achieve coronary clearance and commissural alignment when you're doing your TAVI procedure. So the case we're going to see in a minute is a pretty young lady, 67 years of age, normal size. She was referred due to increased symptoms. She is now in function class 2 to 3. And the local hospital have, during the workup, found a severe aortic stenosis. She got a medical history of hypertension, chronic obstructive lung disease, and she also in the past had a stroke. Echocardiography confirmed that she had a severe aortic stenosis, and also during the workup she had a coronary angiography showing she had a stenosis on the right coronary artery, which was treated with PCI. ECG showed borderline first-degree AV block. Her renal function was normal. STS score showed she was in what we would call a low-risk patient. CT scan showed she had a pyramidal-derived aortic annulus of 22.9 millimeter, almost the same size of the left ventricular outflow tract. Coronary height was high, more than 12 millimeter. And also the sinus of Valsalva didn't give us any concern about coronary obstruction. Access was a bit small. She had the largest sites on the right femoral artery with a minimum diameter of 5.2 millimeter. Aortic arch looks to be suitable for embolic protection using the Sentinel device. So the concern in this younger patients with long life expectancies was the durability. So we were choosing a valve with a large opening area. There was a risk of conduction subnormality due to the pre-existing first-degree AV block. So we need to have a device with low interference with the conduction system. And also, of course, since you already have pre-existing coronary artery disease, we had to make sure we could reaccess these coronary arteries after a TAVI procedure. She had a stroke in the past, so the plan was to use cerebral embolic protection device. She had borderline access vessels, so we're going to use a low profile introducer sheet. So actually the plan was to do TAVI under local anesthesia using a right side transfemoral access with a 14 French eye sleeve, using the Manta closing device, cerebral embolic protection device with Sentinel, and using a pre-dilatation with a 22 millimeter true balloon, and then use an ACURATE Neo2 25 millimeter valve with commissural alignment. So I think before we go to this case presentation, Ignacio, maybe you can take us through how the design is of this ACURATE Neo2, particularly what is the novel features compared to the first generation valve.
Thank you very much, Professor Søndergaard. So we already have some virtues of the ACURATE Neo technology that we know very well, and this include the low gradients and low prosthesis-patient mismatch achieved due to the supraannular insertion of the leaflets. But what we are searching with the ACURATE Neo2 device is mainly a reduction of the paravalvular leak and also a better positioning through the better radiopaque marker during the procedure. There are no changes in the valvular sizing, no changes in the eye sleeve sheath, and no changes in the transfemoral delivery system, which can also be useful through transaxillary access, although this is not CE mark approved. There is plenty of clinical evidence around the ACURATE technology. I'm going to go through some of the most important studies that have been presented in the last years. The first one is the TAVI transfemoral. You know it very well. 1,000 patients that demonstrated a very low rate of pacemaker and a very low rate of more than moderate paravalvular leak. After this study, the valve extended in the market very rapidly, the ACURATE now. But then there were the SCOPE 1 and SCOPE 2 controversial studies that I want to mention. In SCOPE 1, the valve ACURATE Neo was compared with SAPIEN 3, and ACURATE Neo did not establish the non-inferiority compared to this device. The reason for this was mainly a higher rate of paravalvular leak that was associated to higher post-dilation, more contrast, and therefore more acute kidney injury. And the conclusion was that probably the technology had the key objective and was decreasing the rate of paravalvular leak. And in SCOPE 2, the valve was compared with Evolute R and Evolute Pro. And again, what we found is that the non-inferiority of ACURATE Neo, the former generation, was not established for the primary endpoint. There was a much lower rate of pacemaker, but again, there was a higher rate of paravalvular leak, and the conclusions and the work for the engineers was decreasing the rate of paravalvular leak. There are some pitfalls in the design of these studies, and when we have a look at real-life registries, such a high rate of paravalvular leak was not shown when compared to other valves. This is a match study that we performed in Spain with 4 self-expandable devices, matching for amyloid size, degree of calcification, and as you can see at 30 days, the rate of paravalvular leak, moderate or severe, was lower with ACURATE Neo. Indeed, there were not significant differences, but the rate of pacemaker was much lower than with any other device, and this had a translation in a better survival at 1 year follow-up with ACURATE Neo. But since there are the SCOPE 1 and the SCOPE 2, there were some improvements in the ACURATE Neo technology, and this includes this advanced sealing technology. This is very interesting because it's not just a skirt suture around the stent, but it's a skirt that when there is backflow, it opens like a bag. Therefore, it's very interesting for irregular or very calcified anatomy because it performs a special way of sealing on paravalvular leak. This is one case that we performed recently with very much calcification in the annulus and a very nice result with ACURATE Neo 2. And this valve is available in the market in the presentation of the CE-Mark study, including 120 patients, and importantly with EchoCore lab analysis. In this study, 97% of the patients had successful procedure, including only mild or trace paravalvular leak, and no patients presented more than moderate paravalvular leak. This is an outstanding finding, but of course we have to wait for the trial, the IDE trial, comparing the Neo 2 with Evolute SAPIEN 3 systems. We are eager to know the results of this study. We must not forget other advantages of the ACURATE technologies that we already know. First, the conduction disturbances rate is much lower, particularly useful in patients with baseline risk factors for pacemaker need, as those with right bundle branch block, but we can see a significant lower rate with ACURATE Neo, which is also associated with one more advantage, and is the feasibility of next day discharge with this device, which is very important, particularly in the COVID pandemic, as we have seen in the last few months. And finally, this is a very fashion topic nowadays, and is the commissural alignment. We know that ACURATE Neo does not stain much in the ascending aorta, and we can easily identify where the commissures are. In this recent publication by Marco Marbanti, we discovered that Evolute have a 7% rate of impossibility to access the coronary arteries, but even when it is possible, it takes longer time and more contrast to be performed. This is very important. I know that after in the case and also during the presentation of Federico De Marco, they will talk about commissural alignment. We have been working on this, and this is particularly interesting for the ACURATE Neo device. If we can advance a little bit the video, please, we will see that this is feasible with ACURATE Neo. In the case that Professor Søndergaard will present, we will rotate the delivery system in the patient. What we are trying to do is to predict how we should introduce the system in the patient. First, we identify the aortic center line. Then we see the valve respect to the native commissures. We advance it with this program that we have developed, but is also feasible with Trimensio, for example. We rotate the simulation of the ACURATE Neo 2 valve to align with the native commissures. This is 50 degrees of rotation. And if we can advance a little bit the video, please, we can see that this can be performed in a real patient as an alternative way to do it compared to other strategies that will be discussed later. We use this device to calculate these 50 degrees that we have estimated, and with this rotation we advance the system, not manipulating it further within the patient, and we perform the implant. This is a very important advantage of the ACURATE technology, and we can simply verify how the valve is aligned by the cusp overlap projection. If you see cusp overlap, as we see probably later in the case, you can see that the commissural posts are well aligned where the commissures are also aligned, the native commissures. I want to stop further here just to mention that we have practiced this in several patients with very nice results, and we will discuss during this week with a panel of experts if you are interested in this topic. So going back to the final comments regarding ACURATE Neo 2, we know that paravalvular leak rate has been controversial after ACURATE Neo compared with Evolute and SAPIEN 3, but in the initial results that we have from ACURATE Neo 2, they have been able to rate of paravalvular leak. We are eager to know the IDE trial results. And we must not forget what we already know, the lower rate of permanent pacemaker that allows safety early discharge, and also the simple commissural alignment strategies that can be used with this technology, reducing the rate of coronary overlap and reducing the challenges for future procedures in these patients. Thank you very much.
So thank you, Ignacio. I think that was a very great introduction to this ACURATE Neo 2 system. So let's move on to this case in a box here. So this case will highlight how you can actually, on a patient-specific level, have commissural alignment with this ACURATE Neo valve. So this is the ACURATE Neo valve. There's not much new to see here compared to the previously ACURATE Neo valve. This is ACURATE Neo 2. The main feature is that there's an enhanced sealing skirt here, which is going to mitigate paravalvular leak. So, and as I said before, all three sizes ACURATE Neo 2 valve will go through this 14 French eye sleeve. So I'll give it here to Ole, and you keep an eye on the guide wire even as we're coming in.
So this loader goes in, and then we advance 20-30 centimeters. And that's enough, and then we bring this
loader all the way back, And of course there will be a little bit resistance in the sheet because it needs to expand from those 14 up to 18 French sheet. The ACURATE Neo valve is, what I say, is probably one of the most flexible valves on the market. So you'll see, even if you have very tortuous anatomy and acute angulation in the aortic arch, it's taking that corner without any issue. It often makes a small kink or bend on the stent frame, so it will just go around here. So now we are almost into the ascending aorta. And let's pause here for a second. So Ignacio just showed us this re-access study here. 300 patients undergoing TAVI with different devices. All patients had cannulation of the coronary arteries before and after the procedure. And maybe surprising, in 23 patients, 7.7% of the patients, it was impossible to access the coronary arteries after TAVI. And out of these 23 patients, 22 patients was actually treating with the Evolute platform. So those patients, it was about 18% of the patient where you could not access the coronary arteries. And one of the issues is that you don't have commissural alignment. And that means when you implant the valve, it's going to sit in a random orientation within the aortic annulus. As you see here on the left-hand side, if those posts of the valve are sitting in front of the coronary arteries, it's going to be very difficult or maybe even impossible to access the coronary arteries. And that's why we should try to have a commissural alignment, as the surgeons will do, meaning that the commissures of this transcatheter valve will be aligned with the native commissures in the aortic valve. This is going to facilitate easier access to the coronary arteries, and probably also going to mean that the patient have a better durability of these valves. And to do that, you need to identify some landmarks on the stent frame where the posts are. And for the ACURATE Neo2 valve, it's actually quite easy. You have this free stent strut where you can see it when when the stent is loaded inside the delivery system. So you just need to orientate that at a commissure of the native aortic valve. And you know there's been this shift from using a classical LAO projection to this cusp overlap view where the left and the right cusp are overlapping. This was introduced to try to mitigate conduction abnormality, but it's actually a very good view also to have patient-specific commissural alignment. Because if you're working in this projection here, you actually have the commissure between the right and the left cusp on the right-hand side of the fluoro screen. So you just need to position one of the posts at that point, and then you have commissural alignment. And again, as I said, here for the ACURATE Neo valve, you see that small free stent strut. So you just need to position that on the right-hand side of the screen if you're working in a right-left cusp overlap view. So when the system is coming around the aortic arch, you just do some small rotation on the handle until you see one of these three free stent struts on the right-hand side of the screen, and then you cross the valve and do your implantation. And what we know from the ACURATE valve that the three posts outside, just below the three posts, you have this what we call a free stent strut. So if you look here on the stent frame, you see that on the left-hand side of the screen you have one free stent strut extending out of the stent. And now we're in a right-left coronary cusp overlap view. So in this way, we know that one of the commissure is going to be on the far right side of the X-ray. So we want that one of those free stent struts to be there. And you see now Ole did some rotation here as he was slowly moving forward. And we know now we have commissural alignment. Another feature on the ACURATE Neo valve is that you see there's an enhanced radiopac marker on the stent frame, and that should be around where the aortic annulus is. So that's easier to actually to try to navigate from. And we can give the first dose of contrast here. This is the very first one we're giving here during this procedure. And what we see here, we see that the pigtail is in the bottom of the non-coronary cusp, and I also think we see that the marker is where it should be.
Yeah, no, it's good.
Yeah. So the deployment is actually pretty easy. It's a two-step. There's one wheel here. I'll start rotating that. And it's a top-bottom deployment. So you see the first thing which is going to happen is that this upper crown is coming out. And then we see that the top part now is deployed. So, and we can do an injection here just to confirm it.
I have to go a little bit lower.
Maybe you need to come 1 or 2 millimeters lower to push a bit forward, yeah. Next, I take this safety split out here from knob number 2. And if Ole is, you want to give one more contrast, and if Ole is happy.
Let me push 1 or 2 millimeters more. I'm pretty much in the other curve already. Okay, this is it, I think.
Okay, you ready?
Yeah.
So I'll rotate on number 2 here, pretty fast, and it's to full stop. So now the valve is deployed, and you saw this was without pacing. It's a very simple deployment. So now you actually have it here, and one other option is to access the coronary artery. So we were working in a right-left cusp overlap. So if you now change, so you have a right non-coronary cusp overlap, you can see now on the right-hand side of the screen, you have the take-up of the left main. And you can use that to confirm that you actually have commissural alignment and easy access to the coronary arteries. Let's do an injection and see whether anything further needs to be done. I don't see any PVL at all. So that's really reassuring. So we now believe we got commissural alignment.
So it's actually pretty nice. This is the other cusp overlap view where we isolate the left, and you see these two posts are almost overlapped as we want.
Yeah.
So it's actually pretty good.
And let's see how easy or difficult it is to get into it. So the guide wire, of course, needs to be outside the cusps, like this, and it looks pretty much. We can have some contrast.
Yeah, we have. I think it's perfect,
Yeah.
almost commissural alignment. Yeah.
So you see, despite that for some of these valves, it can be very difficult to get in. If you have commissural alignment, which is very easy to achieve, it takes you a few seconds to actually engage the coronary ostium.
Mm-hmm.
So just to summarize here, you see that commissural alignment is important for coronary access, particularly when we're going to move to a patient with longer life expectancy. And using this left-right cusp overlap view during transcatheter heart valve deployment, you just need to isolate one of the posts on the right-hand side of the screen. If you use the ACURATE Neo2 valve, it's the free stent strut. And when it's deployed, if you want to access the left main, go to a right non-coronary cusp overlap view, and then you know that the left main stem is going to take off on the far right of your fluoro screen. So I think after this short case presentation, let's move to you, Federico. I mean, you have been working quite a lot with commissural alignment and access. So maybe you can tell us about your experience with this technique or these techniques.
Absolutely. Thank you so much, Lars. I'm exactly going to show you how we do it here in San Donato. First of all, let me start by saying that we know that coronaries can have some different origins. The angle between the coronaries in particular is not always fixed at 120 degrees. It can be as small as 90 degrees and it can be as wide as 180 degrees. And on the top of that, also the ostium of the coronary might not always stem exactly from the center of a sinus, but it can be also in some weird position inside the sinus. This is why we are not trying to orient appropriately along the commissure, but what we try to achieve is to maximize the coronary clearance for our patient, because ultimately that's what really matters for our patients, to not have the tab, the commissures of the prosthesis in front of his coronary arteries. This is why we developed a technique here in San Donato, which is aiming at placing one of the commissural tabs exactly on the coronary bisector of the angle between the coronary arteries. So as you see, if you have the commissural tab in this position over the bisector of the angle, then the clearance of the coronary arteries for our patient is going to be maximized. So the first thing is that this configuration, the blue configuration, which is the one that you would like, is not easily distinguishable fluoroscopically from the red configuration, the red disposition of the tabs, which are, as you see, in front of the coronaries, which is actually the worst alignment you could have. So this is not distinguishable from the bisector view or also from the coplanar view, which is the standard view which we use to implant the ACURATE Neo device. So in order to be able to distinguish the disposition of the device, we basically rotate along the S curve, as you have been showing, 30 degrees along the right coronary artery. And by this rotation, you basically send two of the commissural tabs on the right side of the screen, and you have one single commissural tab seen sideways on the left of the screen. You could also refer, as you were saying, to the free stent strut. But this configuration with two tabs on the right and one on the left is the configuration in which the valve is correctly aligned in order to maximize coronary clearance. And then we go back to the coplanar view to release the valve. So the problem is how to rotate the valve here. So we know that trying to rotate the valve after you negotiated the aortic arch can be difficult. You can store a lot of torquing energy inside the device. You can also have some release of energy during valve release. And also the rotational inertia is such that it can be very hard to rotate the valve after the aortic arch has been negotiated. So what we do is basically we pull back the device in the ascending aorta, and we rotate our delivery system with some specified angles. So the first angle which we rotate is 180 degrees. So pushing the flush port towards the bottom of the table. The third angle that we test is facing with the flush port facing away from the operator, and the fourth angle that we test is with the flush port facing towards the operator. Basically, due to the 120 degrees rotational symmetry of the ACURATE Neo valve, by testing these four configurations, you are going to end up for sure within less than 30 degrees from the coronary bisector. So you are going to need exactly up to 3 rotations of the delivery system to achieve the correct alignment in order to maximize coronary clearance, with 2 tabs on the right of the screen and 1 on the left of the screen. So maximum 3 rotation in the descending aorta, where it's easy to rotate the valve and where you're not going to store up energy in the delivery system. So we ran a little study. We tested this strategy in 45 consecutive patients undergoing implantation with ACURATE Neo or ACURATE Neo 2. And these patients underwent also a follow-up CT scan after the implantation to verify for the correctness of orientation of the device. So our primary endpoint was to see if we were able to land the Commissural tab on the coronary bisector with less than 15 degrees rotational error from each side. Secondary endpoints were the evaluation of the severe coronary overlap, which we wanted to avoid, which is defined as a Commissural tab within 20 degrees of a coronary ostia. And obviously, we also referred to the standard definitions for commissural alignment with the degrees of error from commissural alignment. So basically, our results were that the mean coronary angle of our patients is, as you see, a bit larger than 120 degrees. It's 143 degrees. The alignment view, which we use to check for before valve release, before going back to the coplanar view, is a very reachable projection, is 20 degrees LAO and 10 cranial. So it's very easy to get there and to check if the valve is properly aligned before release. And after this is probably the interesting results, we were able to land with 1 tab on the bisector within 15 degrees of the bisector in 93% of our cases, 42 patients out of 45. We had no case of severe coronary artery overlap, and in 95.5% of cases, we had at most a mild misalignment. So we had a maximum of 30 degrees of rotational error with respect to the commissure. And we were able to selectively engage both coronary arteries in all our cases. This is a standard example of a CT scan after the implantation. As you see, the valve is nicely oriented, and the coronaries have a lot of space in front of them, and the angle between the coronaries here is much wider than 120 degrees. And so my conclusion is that since the coronary ostia location is variable, they do not always originate from the middle of the sinus of Valsalva. What we want to have for a patient is the maximum of coronary clearance. And to do this, we place a tab of the ACURATE Neo over the coronary bisector, and this secondarily obviously achieves also correct commissural orientation. We like to do the rotational manipulation of the device in the descending aorta, because that's where the device is free to rotate, so in order to avoid any issue with the delivery system. And also our patient-specific CT scan-based algorithm was effective in orienting the device with less than 15 degrees angular error in 93% of our cases.
So thank you, Frederico. That was a very excellent talk. So I hope that all of you saw that it's very important to optimize the TAVI procedure, particularly as we move to patients with longer life expectancy. And I hope you understand now that commissural alignment is actually possible, and that with ACURATE Neo2 valve is a good valve for that. It got clear landmark, it's very flexible, so it's easy actually to rotate it inside the patient to have commissural alignment. Ignacio, anything you want to add to this?
Yes, I think in some patients this rotation can be challenging if there is tortuosity, and maybe a combination of this rotation in the patient to correct an already predicted orientation of the device before entering the patient could be useful. But of course, the technique explained by Federico could be also useful.
Yeah, I think Ignacio, I think you showed really a smart concept. I mean, the one to predict how you should insert your delivery system to achieve a good alignment is really a smart idea, and I'm really looking forward to see more in-depth results of your technique. And as a general consideration, I think really since TAVI procedure is growing, I mean, it's gaining widespread use even in younger patients, we should definitely do as the surgeons do. We need to implant the valve correctly orientated. There is no doubt about that.
Yeah, I fully agree. So Ignacio and Federico, thanks a lot for being part of this. And for all of you who have been watching this session, thank you for joining.
Thank you.
Thank you.